Hello, everybody in internet social media land. It's Paula Nutting, your musculoskeletal specialist, and it's our monthly Ask Me Anything post where today I think I've pulled somebody who is, I'm not going to say a magician, a little bit of magician, steeped in knowledge, gorgeous fascial being. Her name is Jan Trewartha. She is the director and founder of the Fascial Hub in the UK. And we are blessed to have her on today for the next 45 to 60 minutes to talk and answer your questions about scars and adhesions. So if you've got questions out there, I want you to get up into that comments box and type away so that we can help you with yourself or with your clients and patients. So without further ado, I'd love Jan to come on board so that we can spend a little bit of time together and help unpack exactly what results we can get with scars and adhesions.
Sorry. Hello, everybody. Hi, Paula.
Hey, Jan, it's great to have you.
Frog in my throat there, a quick cough.
You're absolutely allowed to have a frog in your throat. That's the beauty of live stuff.
Yeah.
It is live. They say never work with animals and kids, but it's hard to work in this kind of space as well. So, welcome, Jan. How are you?
I'm good, thank you very much. Yeah, it's not too early in the morning. I'm grateful.
Yes, UK, it's about 9:30, I think.
It's
somewhere
not
around
bad at all.
Exactly. Before we kick off and talk all things connective, no, not connective tissue, but partially with scars, I just want to do a quick plug to our wonderful sponsors, which are Q Academy. So Q Academy are based in Brisbane, but they are well renowned as the largest myotherapy educational system that we have in Australia. Myotherapy is kind of like a elevated advanced diploma. They also have an associate degree that hopefully will get passed in the next 12 months. So we'll have this amazing step into the space of higher education. So very, very excited about that. But if you're looking at doing a sea change from some of the old courses that you've done, or maybe thinking about what would it be like to become a massage therapist, diploma in remedial massage or myotherapy, please look up Q Academy because they are absolutely amazing, and I'm happy to sponsor them at every stage. The educational platform is amazing, and they teach in ways that just makes you laugh and engage all the time. Anyway, enough said about these great guys. I don't know if you have associate degrees over there in the UK for massage therapists.
Possibly the nearest thing. Some of the universities teach it. But it would be a degree in all things complementary health. Yeah. Jing do a BTEC, which is probably one of the more advanced degrees. I don't know if it's degree level. They'll tell me off, but it's a BTEC. And it's quite a long study.
And that's it. It's trying to get some value add in the complementary medicine side of things. So that's good. Jan, for the people who don't know you, the people who have been living under a rock for the last 20 years, I suppose, how long have you been in the industry, and how did you get involved in scars and in this space?
Okay, well, I was originally a state registered nurse, well, a trainee nurse, then a state registered nurse in Her Majesty's Armed Forces in the UK. So I was an army nurse. And I didn't see any action, but I was mostly based in England, but I did that for 4 years, and then I left, and then I went into the NHS and worked there for 3 years. But there's something inside me that just told me it wasn't right for me. We were giving drugs that then later we'd find out were banned in America. There's all sorts of little things. They do a great job, but for me, it wasn't right, and it was quite a time of change. They were bringing in something called the nursing process, and everything was changing, and it's a very different world now.
Is the nursing process like a 3-year degree versus in hospital training, that kind of change?
Well, mine was in hospital training and theory. We did class and in hospital, but we were in hospital from the very beginning, and emptying bedpans.
Same here. Same
From the very beginning. Were you a nurse as well then?
Yes, straight from school to nursing, 17 and a half, 17 years old.
Yeah, I was 19. It was, very, very early.
Yeah. I
And
remember
I suppose just in the end, if it's not it's not true for us, and it's not right for us, we move on to something different, don't we?
But it's fabulous because you get an anatomy and a pathophysiology base, and you get a pharmacology base.
Yeah.
So it's a really wonderful platform in which to step forward into.
It is excellent. Yeah. Yes, I'm grateful for the background knowledge I have. But I went I left nursing and all of that totally. And I got a job on a magazine called Ski Special. And I couldn't ski. I was very good at après-ski, Paula. That was very good. And I did learn to ski in the end.
Wow. Oh, that's better.
I see you've got different weather over there than we have.
Yes, I'm actually melting in this room. My partner shut the door because he didn't want to make too much noise. And I'm like going, melt.
Yeah, we've had our melting bit this summer. We're back to normal now.
What were you doing with the in the space of the ski area? Were you writing?
Well, I just had 3 years writing about skiing, going abroad skiing. It was fun. But in the end, to me, I'm a carer. It was shallow for me. There's only so much you can write about skiing for me. It just wasn't the right job. I loved it. It was great fun. And I learned. That's where I learned, because I went from editorial assistant to assistant editor. And that's where I learned my editing skills and my writing skills, which come in very useful now running the Fascial Hub.
Yes, because
I'm commissioning, I'm writing, I'm editing. It takes up half my week, the Fascial Hub, and love doing it. But that's where I got those skills from.
Yeah. How long have you been doing the Fascial Hub? How long has that been set up for?
Well, I originally started the British Fascia Symposium, which started in 2014 and ran every 2 years. So 14, 16, 18, May 20. Booked in person. We didn't use that phrase then, but in person near Birmingham. So that's northwest England, well, Midlands really, and we went into lockdown, and so I had a choice really. I could cancel it and reschedule it for the following year, but my gut told me, luckily I've got a very good informative gut. My gut told me that wasn't a good idea, and so I went online with it, and we did 5 days of broadcasting from my clinic room. I was in my clinic room. My producer was in London, and our assistant was in Holland, and the tech support was in Holland, and never done anything like it before. Well, I hadn't. My production team had. And we did have a few ups and downs, but people were so forgiving. They were so delighted. They were so delighted that we were online. Yeah. And we had this massive audience, having had to sort of refund an awful lot of people and, stand holders and all that stuff. People bought tickets. It was amazing. They just couldn't get enough of us. Yeah. And at the end of it all, after 5 days, people were saying, what are we going to do? We're so isolated. We're so lonely. We're so this, we're so that. And not just during the lockdown. I got the impression that people were pretty isolated in some countries anyway, as therapists. So when I was sitting in the garden collapsing afterwards and also resting on my laurels because it had been this massive success, and I don't know, it was just it was stressful, but once we got into it, it was just such a joy. I really enjoyed it. And I'm the last person, I don't like having my photo taken, let alone doing this stuff, but I found that I really enjoyed doing it.
Well done.
I had this thinking we need to set up some kind of community for the people in the world of fascia, and that's primarily therapists and movement educators. Of course, we draw in also osteopaths, chiropractors, some surgeons, physios. We draw in people from all the modalities, but the essential heart of it, probably massage therapists, sports therapists, movement educators, Pilates, yoga, things like that.
Yeah.
And so I thought, well, the Fascial Hub, really, it would be a hub for people, anything to do with fascia. And we launched with, what was it, the fascial foot or fascial spine? Fascial foot, one of the two. A big event. 600 people came. I thought there's something here. People really need this information. So now we focus on providing reliable information, regular events. You can be a member or a non-member. Of course, if you're a member, you get all the perks, the in-person events you get first booking for, you get discounts, you get all that stuff, and loads more information. But you can be non-member. You can just come, look on our homepage, scroll down to the bottom. There's loads of articles. You can join the events. You just pay a bit more than a member, that's all. So it depends whether you want to immerse yourself or you're just vaguely interested. So that's the Fascial Hub, and we've been running now since May 2020. Yeah.
Wow. We've already got, like, we're gonna get into this, but just while I'm seeing things, there's Sandra who's asked a question, and then she said my screen totally froze for some time, which was brilliant because we didn't discuss it. At some stage, she's interested in fibrosis, particularly around surgical scars and lymphedema. So we will unwrap into that.
Yes.
But how did you get into this? Where did your journey come to scars? I mean, part of it was like army.
Yeah. Well, I went to the Fascia Research Congress in Vancouver, in Canada, and I didn't really know much about fascia or anything. This is why I started British Fascia Symposium, because I thought I'm not alone, not knowing much about this. And I met Sharon Wheeler, and I have a scar, and a pretty bad scar, 2 scars that cross over. And I was beginning to suffer the effects of adhesions. Not that I knew much about what was going on at the time, to be fair. And Sharon worked on me, and I said, oh, I've got to come and train with you, because that was remarkable. And she said, oh, well, I only really teach structural integrators and Rolfers because they understand that everything in the body is connected. I said, well, I understand that. Anyway, I slapped down all her nose and went over to America and trained, and then brought her over to England, and the rest is history. It's taken off in the UK, and Sharon teaches around the world. I'm teaching in Spain next year. I'm teaching in Ireland next year as part of the national training, the NTC in Ireland, as part of their higher diploma in neuromuscular therapy. They want the scar work as part of that, which is a huge honor. And then I wrote the book as well.
And her name. Yeah. Amazing. I read that book and went, oh my God. And then I looked at the videos and went, truly my giddy aunt. And then I contacted both of you to try to get you to come on board to throw this space out, because so many therapists are actually, now that we look at fascial integrity and the body as a whole unit, more remedial therapists, especially in Australia that I know, would value so much of that. We have so many people that we treat scars ineffectively.
Well, Sharon has started teaching in Australia. I think she's been over twice. She's also taught in New Zealand. I'm open to coming, just need somebody to host me and organize me. So, we do get around, and the rest of the world. Sharon also teaches in Japan and all sorts of places around, lots in Europe, of course, lots in Poland, and Germany. So yeah, it's worldwide now. And the thing is, I've never trained in any other scar modality, but I'm not doing that down. It's just, I have everything I need with Sharon Wheeler's scar work.
Yeah.
So I don't.
Yeah. It's so gentle, and it's different to what so many other people talk about scarring and how to treat scarring. Susan Chappell, who I absolutely adore, she's in Squamish in Canada. She does brilliant scar work, and she's done research with rats and stuff like that. And I love her work too. But this, I have you, and I want us to talk about this. So tell me, with Sandra's question, can we touch on that at this stage?
Yeah,
fibrosis around surgical scars and lymphedema?
Yeah. Let's just start with the basics, that there's no such thing as an isolated scar. And you can have a cesarean scar or a tiny scar under there from falling over as a kid, or you can have any scar under the sun, open heart surgery, hip replacement, anything, or a tiny little scar from a bit of glass on your foot when you were a kid, whatever. That is never in isolation. Because of the fascial matrix, I don't know if I need to explain that. I think everybody's pretty up to date now with fascia and the fascia matrix. Because of the fascia matrix, there is full connection within the body. So everything is connected. It's not a series. The body is not a series of isolated limbs and layers of structure and layers of tissue, as you would find in your general anatomy books. And there are lots more really modern anatomy books out there now that talk about the fascia. So the information is out there. And when I first went to my my first dissection course with John Sharkey, and I know you've had John Sharkey and Joanne Avison on here, so you know about this. But I was with John Sharkey at his first field dissection, which is where they have the cadaver is soft fix. In other words, you can pick up the hand and it just feels like your client has fallen asleep on the couch, but it's slightly moist. It's a very strange feeling. But the thing is, the tissue is as much like real tissue as you can get, really. And I was on Joanne's table. We were dissecting. And what we did was we dissected the anterior shoulder on the left, and we dissected the top of the foot on the right. And then she moved the foot. And you could see the tissues in the shoulder moving, and vice versa. And that was my I knew it, but I actually got it when I saw it. It was, aha, oh my God, really? So then I'm thinking, okay, well, when I was writing the book, what happens if you have a scar here? You know, or what happens if you have a scar on your foot? That has to potentially globally, but at least locally and probably a bit more, affect the tissues around it and then connecting through the body. It has to. And it's not just a question of compensation patterns. That's a different thing. Of course, that's part of it. But it has to connect. And if you've got a major scar on your shoulder or on your foot, even at opposite sides, diagonally opposite, then you are going to, and there's not a question of it may, you are going to have some kind of engagement, some kind of distortion going on in the tissues because of this fascial connection, full body fascial connection. I've seen it with my own eyes. So it's the basics. So when you're talking, is it Sandra, you're talking about fibrosis and lymph involvement around a surgery? Well, it doesn't matter where the surgery is. Yeah, of course, if you're near major structures, they're going to get involved because the fascia, so everything goes through fascia. So the nervous system, circulatory system, lymph system, everything is surrounded by fascia. All the structures are surrounded by fascia, right down to within the cell. So you cannot, again, have a surgery, even a tiny linear scar, without having distortion through the other tissues. Could I show you here one of those examples I showed you, the one of the feet?
We might get Tin to bring that slide up.
I think this might help. Right, okay. So can we make that one larger, the full screen, please? Is that possible? No? Okay. So before and after. So this lady here, we didn't take very good photos. This was right at the beginning of my teaching. Hadn't even realized what the photos could be like. So they're not very good photos. This was just done by a student. I taught them the first 9 techniques, and I said, go away and practice on a simple scar. So this is a simple scar in that the woman had had tendon surgery in her teens. She didn't remember what for, and her parents were no longer around, so she couldn't find out. But she'd had this tendon surgery. Now you can see, no, I haven't got a cursor here.
Like the little toe is completely buckled under.
You can see the little toe is totally pulled under. You can see no self-respecting surgeon would leave a scar that crooked. Yeah. And because of the adhesions that are clear there, pulling in on the top of the foot, and the distortion in the tissues that's happening, it's not just the linear scars that are affected. Excuse me. Excuse me. The whole foot is affected. You can see that the grip in the toes.
Yeah.
And the whole thing's being pulled probably from underneath. And the little, every toe is tucking into the other.
You can see that callus on the little toe at the after section. So that's how that lateral portion of that fifth ray has been rubbing against every sandal or shoe or whatever she's ever worn.
Yes. Now, she was due to have surgery at Christmas, which was about 3 or 4 months away, and she cancelled the surgery. My student worked twice. I think it was two 1-hour treatments. And this is what happened. You can see she likes her feet more. She's got polish on them. Her linear scars have straightened out. The little toe has come nearly all the way around, and the other toes are not tucking in. There's just the big toe and the second toe are still rubbing up against each other, but I don't think that's bad for 2 hours treatment. Now, what you've got to consider here, and this is going back to Sandra's question, is what other structures were involved? Undoubtedly, probably, I'd say the right ankle, maybe even affecting the right knee. We get people with things like this or cesareans, and they're having knee replacements or hip replacements down the line. I'm not saying the scar is the only cause of this, but I'm saying it can be majorly contributory. Yeah. So this lady had her 2 hours. She cancelled the surgery. She didn't need it, but she also then needed a lot of myofascial work to release, if you like, or to free up the patterning that had developed in her body throughout the whole body, compensation patterns that the body normally will just do, but also the fascial tension. It's almost like a 3-dimensional domino effect. It goes straight through all the systems. And so what's in the way? Well, the knee, you've got the whole of the knee, the structure of the knee. Then you've got the whole structure of the hip. Plus you've got the muscles in between. You've got the nerves. You've got the lymph. You've got the circulation. So you can, and it will vary because it's not black and white. You're not going to say, well, if you have a foot like this, you're going to get blam, blam, blam. No, not necessarily. What's your lifestyle like? Do you move? Do you have good muscle tone? Have you got previous injuries? Have you got other scars? Because the tissue from scars will feed into other scars locally under the skin. So a cesarean will feed into a hip replacement scar eventually. Some people stick quicker than others. Some people don't move, they stagnate. Some people don't get their circulation moving. So their muscle tone is poor. There are all sorts of different things. So you can have a cesarean scar. We could stop showing that one for the moment, actually. That was just thank you. We could have a cesarean scar, and I have a case study in the book you will have seen. And she had she carried the baby on one hip, baby hip. So as you carry the baby on one hip, it's the same as if you carry a handbag on one shoulder, or your sports bag on the shoulder. Or like one of my clients, he reached down his round, instead of getting up and flushing the loo, she used to reach around and just flush the loo like that every day, once a day, all her life. And we couldn't work out what this pattern was in her body because I do fascial positional release on fascia. So you can see what they're doing. And what happens is that when the fascia is required to do these repetitive movements or consistent movements, it will respond. Fascia responds to the forces in the body. So it will lay down protein, collagen, along the lines of force, as most of you probably know. So if you've got somebody with a cesarean, but they also carry the baby on the right hip, for example, that baby hip, that hoiking of the hip, will eventually be reinforced by this collagen deposit that will reinforce and make the hip appropriate for what we are requiring. That's very intelligent.
Structurally out of balance.
And then you are totally structurally out of balance because you've got one hip like that. But then that tissue is no longer good, mobile, lovely tissue, and it will feed under the skin Now, I've seen one piece of research on this, but it needs more research. But I see it again and again and again, and it will connect. And you then have this cesarean scar that's pulled into the anterior iliac crest and stuck into the periosteum, and the rest of the hip is stuck around it. So you don't need to just treat the scar. You then need to get them to change their habits, and they need fascial release work. They need the fascia work. Massage won't cut it on that.
No, I had a interview with a woman called Danielle Valoris, and she talked about breast implants and the dangers of them, and the fact that the adhesions occur within hours of that breast being augmented. So the breast is there, and then it's just building this capsule that looks like a baseball mitt, and just the changes that we see with the scars through there. Robert Schleick was down here in Australia for the 11th interdisciplinary conference on lower back and pelvis, but we were lucky enough to have a 3-day workshop with him in Sydney. And he was saying that the studies now, the research is saying that the fascia moves at about a centimetre a month. So I guess that's why we can get away with baby hip and not having pain for a length of time until that train line of connective tissue has just...
And then it's just like having a vice around you. And you have to mobilize. You have to mobilize. You have to do the work. And it depends on the person. Depends on a lot of things about them, and depends on their mobility. Often depends, I believe, on the state of mind. Research to be done, but I think so. And people get stuck, literally stuck. They get stuck in their life. They get stuck in their body. Sometimes, and they need help. And some people need more help than others. Others, you do a little bit of work too, and they're off. They're off.
With the scar release work that Sharon's treatment model, do the patients have to do an exercise? Like, is there home treatment that they need to do?
No, they don't. No. I do give people occasionally some exercise, for example, for episiotomy, because I don't really work on that in the clinic unless they want me to, and unless it's really severe. For example, if it's there has been no episiotomy and they've torn vagina to anus or past, that kind of thing, you can work on. You can't necessarily work on that unless you have a background as a nurse or a doctor or something similar. But I can work on that. But normally with episiotomy, I have, I can tell you if you like, if that's interesting. Yeah. So there's this technique called dropping. As you see, the techniques are very light. And this is just, it's not a hit, it's a drop.
Yeah. There's 5 different techniques in the scale work?
Oh, no. That's just what we gave with the book.
Got it.
Yeah, there's about pushing 30 at the moment. But the interesting thing is it's not the techniques that are so important, it's the approach, Paula. This is light, it's gentle, it's non-invasive, and the skin responds almost instantly to the light touch. I usually say to people, right, feel your scar, because it's going to feel different in 10 minutes or 20 minutes. I know that. For a fact, I know that. On certain scars, some won't respond as quickly and easily. It depends, but say on a cesarean scar, they feel it, and very quickly, it starts to change. It gets really soft. And when they get up from the session, they often say, oh, I feel like I've been joined together again. I was cut in half and now I'm joined together again.
Wow. So the scarring...
Back to the episiotomy. Yeah, exactly. It's like that connection. So back to the episiotomy. What I do is I get women to go home and lie on their back, say on their bed, with a pillow under the bottom, legs up against the wall, like that. And with one hand, very, very gently, obviously they have to strip off for this usually, or through knickers is okay, and they just literally drop. So you've got the perineum. At what angle that would be, sort of like that, and you'd be dropping like that all around the vagina, all around the perineum, not hit, nothing like that. It's drop flop, 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 drop. Because when you're at that angle, you can just let your hand drop. And that, I've had very good feedback from that. And one woman actually said that it had helped her incontinence as well, which had been awful since the episiotomy. And that's all you have to do. Are you frozen at the moment?
Sorry, we just had a bit of a...
me, or is it me, or is it you freezing?
I'm hoping that we're both back.
Hopefully.
Have you got me?
Yep, I have.
Yes, good. Excellent. So I did get the drop. So I think we actually got that information, which is brilliant. We had the question about lymphedema, and I've also got another question from Lucy.
Oh, sorry. Yes, the lymphedema. May I just, the lymphedema. Yeah. The restrictions created by the scar are going to create a slowing down in our different systems, or they can do. For example, they can restrict the mobility of major organs, which affects their functionality. Obviously, can restrict the joints, affect your range of movement. It can affect your lymph flow, blood flow, your energy flow, the one that you can't see. So lymphedema is quite a normal thing. And so if you work on somebody with scar work, and then I also teach fascial unwinding, which is very, very light, gentle work. And I had some MLD, manual lymph drainage therapists I taught both to up in Edinburgh a few years ago in Scotland. And they said it was amazing because the women came in with the lymphedema in their arms after breast surgery. And what they did is they would use the fascial unwinding and then the scar work, and then they'd use the lymph drainage, because it freed everything. Then they could use the MLD to get everything moving again. The thing is, you can't run a car through a roadblock. That's it. They're going to back up. The cars are going to back up and back up and back up. And that's what happens. You've got to gently, gently move the roadblock out the way. And then slowly the queue will start to clear. But you can't just shove something through a roadblock.
Isn't that
it's sometimes, and I know lymph drainage and people so a lot of modalities have techniques for working with scars. They need them. You need them. You can't put anybody right until you can't rebalance somebody, get them out of back pain permanently if they've got scars in the way. How can you?
Yeah, very true. We all have dozen, in or out. So Lucy's got a question. I have abdominal adhesions following section diagnosed after a laparoscopy. Ornamental. She has them on the ovaries, bowel, and tubes. Can this type of treatment help with these areas, as it is crippling just to add slight pressure to the tummy? I'm waiting for the surgery, which is scary, and I would love to avoid it. I'm in the UK and losing hope of ever being myself again. You must hear things.
So sorry to hear it. I know. I belong to some groups with scars and adhesions, and I did advertise this actually to one of the groups. So I hope that's got out to some people. What was the original surgery again, please?
Abdominal adhesions after diagnosed via following section. I'm guessing a C-section.
C-section. And then they went in as a laparoscopy to see what was going on. And the trouble is, every time they cut in, they're going to create more adhesions down the line. And some people, Lucy, just stick more than others.
Yes.
And the C-section, yeah. It's very hard. I can never say, yes, this will cure it. You know that. No therapist worth their salt will ever say, yes, I can cure it. What I'd say is with Sharon Wheeler's scar work, you are likely to get some relief from it. And then if you combine that with some specific work like Zoga, which is what Wojciech Kakowski teaches in Poland, I think he might be doing it out online now. It's called ZOGA, Wojciech, WOJCIECH. His name's on the front of the book, Paula.
Oh, yes.
Yes, so Wojciech Kakowski. Paula will try and find you that link, hopefully, to Zoga. And he was in the book, working with specific movements designed to help scarring. But I'd say, I run courses in England, and we welcome people who'd like to come and be worked on for free by the students in a supervised capacity. So if you contact me, jan@bodyinharmony.org.uk, jan@bodyinharmony.org.uk, Lucy,
that's down in that.
we can get you on the mailing list. There's a course running in February and March in Maidenhead in Berkshire, and you could come for free. That would be fine, and we could see what we can do. I would say it will almost certainly relieve something, but I don't know. I don't know you. I don't know your history. I don't know until I see you, but we can usually make a difference, is what I'll always say. We can usually make a difference. There's very few people I can't make any difference to, but there have been a couple, to be fair,
Unbelievable.
Right. I hope that helps, and I'm so sorry you're going through this. I've joined some of the scars and adhesions groups just to see what's going on, with the permission from the facilitator, and to offer the free places as models, scar models, we call it.
That's perfect. That's absolutely perfect.
So
I've got Belinda, who's an Aussie therapist.
Hi, Belinda.
About keloid scarring.
Oh, yeah.
So keloid, to my mind, has always been around specific non-Caucasian, so different kind of ethnicities, but not always.
No, not always. No. It does depend. It does depend on your own heritage, but in England, I've seen scars on people who don't seem to have any heritage from. It's usually places like Asia, Afro-Caribbean. If you look on YouTube, you'll find some really awful pictures of people who've just had their ears pierced, and then they've got this huge keloid, which then covers their face and ear. I mean, it's terrible. And I wouldn't say that we can do anything about that. However, we are starting to develop techniques for little small scars that are keloiding. We are starting to have success with that. Yeah.
And my brain was wondering, I hope that helps, Linda. My brain was wondering about endometriosis.
Yeah, endometriosis. We don't go internal, but we have some techniques that dropping is one of them, just dropping.
How
There's
deep?
a certain way to drop on the abdomen. There's a certain way, but you can try it, but it's just light. Sorry, Paula.
So, obviously, somebody who's had a total hip replacement, you've got the scarring around the actual attachment through the acetabulum, or the actual ball as it goes into the femoral shaft, but you've also got the muscle scarring, the skin scarring. How much do we unpack that, or is it just kind of one big, because the fascia is all just one big connective network that
you're going to get a better result? You could approach it like that. We don't. Are we going to get a better result if you start with the skin on the top and connect that back up? Because even when you cut something, when you cut the skin, and then you sew it back up, probably under the microscope, unless you've got a plastic surgeon working on you, it's going to look a bit like that. If you've got a plastic surgeon, it's probably going to look more like that, if you're lucky. But so we worked first to start to connect the skin back to where it should be. Of course, if you've got something like a diep flap or a tummy tuck, where they take out a huge wodge of belly fat, either to just remove the fat or to create breasts. If you're having a diep flap after breast surgery, mastectomy, and then they can build 1 or 2 breasts with the tissue, what happens is they're taking the skin. So the edges, when you match them up, when you look at a diep flap or a tummy tuck, instead of being quite neat like a cesarean, they often look quite taut and strained and stretched, because they pull down the abdomen, and they recite the navel and pull down the abdomen and then pull the skin edges together. So it does look quite tight.
Yeah.
And working as a scar work therapist on that, it takes a lot more to try and connect to two edges of skin that have never met before. It's like reintroducing old friends, or trying to get new two to become friends. It's a big difference. Yeah. So I've got a little bit off the subject there. Where were we?
Oh, about the how they unite or don't quite unite.
Oh,
in
yeah, we're looking at the difference, yes. So although
layers.
the body isn't in layers, you have planes of tissue. So we're looking at this, we'd be working with the skin superficial fascia, then we'd go drop down deeper and drop down deeper. If there's a bone underneath, we'd be intending into the periosteum, because it's also the power of intention of how deep you're going. You can feel how deep you're going, but you can use your intention. This is very, very light work. So, but we're not going down in to work on the periosteum. We just drop in and your intentions on the periosteum.
Yeah.
Okay. And if you can create a really good connection between the edges of the skin on the top, that will, I suppose it's trickle down effect, I suppose you might say, but that will ensure a better connection underneath.
Yeah, yeah. I mean, that's Newton's third law. Every action has an equal and opposite reaction. So if your intention is that depth, that's where the neurosensory organs are going to be coming back up to speak to you.
And as you work, you'll be working on the free nerve endings under the skin, and you'll be working deeper. You'll be working as you work. It's more like, rather than doing to the body, I see scar work, Sharon Wheeler's scar work, I see it as facilitating the body. The body knows what it needs because, and this is something really important, and this is my mantra, the tissue always goes home. Tissue always goes home. So you can push tissue where you like, and you think, well, that bit ought to be there and that bit ought to be there. But if it's got to replay a pattern before it goes back into place and settles, then you can push it in as much as you like. It'll come out again. But when the pattern, the underlying patterning in the body is corrected, then it'll go back into place and settle.
Yeah, because it wants to be home.
Feeling. If it's not home, it's not going to settle there. So, I can try and push something back up. If it doesn't need to go up, it's not going to go up,
Yeah. How interesting. Yeah. So Jan's just wondering how this would work on ligaments, tendons, and labral tears. Yes, Jan, I've suspected labral tears. So, yeah.
Ones that have been corrected through surgery, you mean, the labral tears? Or
Jan, are you saying that ligaments and tendons have been injured or surgically, or like, has it been surgical scars, or have they been like strains or sprains? So if you could just qualify that for us, Shane, that'd be unreal. Yeah, and to feedback off what Belinda was saying, that she's got one of her clients who is pregnant, and the doctor's suggesting, because of her keloid potentiality, is saying go through natural birth, not having a Caesar. So that makes sense.
I mean, you can, there are things that the medical people do offer. Some people will offer steroid injections into keloid, and no doubt sometimes they work, but I also have a picture in the book of somebody who had a pimple on the chest that was injected with steroid, and she now has a long, rather ungainly scar right there. So I'm a little bit cautious of that. However, sometimes keloid scars are not just ethnicity, it can also be with the pull. So people maybe who are sort of white British going back generations or whatever, women particularly here can keloid, and because the strain of the breasts, the pull down can create a keloid. So it can be the pull down. Somebody who could, if somebody's got a very large tummy and they've had a hernia op, that pull can create the keloid. So there's that as well. So if you're you might want to, I don't know if you have that sort of ethnicity that is more likely to have heritage, that's more likely to have keloids, then yes, of course, avoid a Caesar. But if you end up having a cesarean, I wonder if your surgeon might be willing to apply tape after the surgery. Some surgeons are, and it takes some of the strain out of the surgery. It's just one thing, but there are also lotions and potions and creams and all sorts of things now on the market. People are developing. I was at a research congress in Montpellier, France recently, and they're doing some really good work on keloids, actually. Nothing to do with hands-on work, but they're doing some really good work on keloids. So there is more hope developing in that way. And for the hands-on stuff, we are developing.
Okay. So that's with creams, lotions, like particular product, you're saying?
I'm not. I wouldn't know a particular product. I'm not a product person. I'm a hands-on person. But people are using tape. Some surgeons are using tape to prevent keloids. That's worth looking into. That's all. You know, whether that's going to work if you have that heritage that creates keloids just like that, then that's doubtful.
You're up against it, aren't you? Yeah.
You know, there's a lot of work going on. So take heart, people. You know, you've got a keloid. There's a lot of good work.
Yeah, and none of us live in cotton wool wraps, so there's always going to be scars. Yeah. So Shane was saying it is after surgery or sporting injury. So I think that we won't look at the labral tear, but maybe ligaments and tendons. We can work using the method with those kind of things first.
After any surgery?
No, non-surgical.
Oh, non-surgery. Well,
not enough knowledge.
There's one technique called featherlight sweeping that I use for fibrosis and techniques and frozen shoulder, and that can have an effect. I've never tried it on what you're talking about. I'm sorry.
Yeah, sorry, Shane.
I suspect not. I suspect not.
Yeah. Mark, actually, this is great. Mark's asking, have a client post-brain surgery to remove a tumour? Firstly, how do you work with the fascial, the scalp tissue, and then work around where the bone was removed? So it's in the temporal parietal area. Thanks in advance.
Okay. Firstly, you need to be insured. You need to be insured if somebody's just had a brain tumor, which is malignant, removed. I would leave it for a while and then settle it before you start going in. Let the natural healing process go on, and maybe 3 or 4 months down the line, if you are qualified and insured to work with carcinomas and post-cancer patients, then that's fine. If not, then you need to either do the course, get trained, or you need to make a work in conjunction. And I would, that soon after that kind of surgery, work in conjunction with the oncology team.
Yeah.
And make sure they know and that they're happy for you to work on it. Because although it's very light work, you've always got to be careful in these cases. Yeah.
Yeah. So Mark, I know, is in Australia. We don't have the same legislations that you have over in the UK or we have different health training packages, etc. We'd also be signing off with the oncologists, etc., to work in with multimodality team. But I think that he's right if he's looking at an area that if you're working from the top down, just working on the scalp in itself.
Yeah, well, you would use featherlight sweeping, which is the first technique, and this is in the book. And the link to the these videos is also given in the book. It's part of the book. Yeah. And those 5 techniques you can do an awful lot with. So you do featherlight sweeping, difficult if the hair's growing back. You wouldn't touch the wound if it was weeping, infected, anything like that, obviously. And you've also got to be aware that if he's had, say, radiotherapy, the wound and the whole area of the skin can be very red, and it's probably best to let that all calm down first. So when it looks like it's starting to heal and it's healthy, then you could start work on the skin first. And of course, there's not, sorry, Paula, I'm just talking over you for the minute while I've got my chain of thought, sorry. But so then you would work, there's not much fascia and muscle then between that and the skull. So there's not much to work with, but the essential aim would be that the skin with the scar didn't get stuck to the periosteum underneath and stuck to the skull. That would be what you'd aim for, so that you've got natural motility. Yeah.
Beautiful.
But light. That's all you need to do. People go plunging in, and we used to knuckle it. You know, when I was a nurse, they used to say, knuckle it, break it down. You want to do that on a breast surgery or, you know, a sort of intimate surgery anywhere, you go ahead. It's horrible. It's horrible. This light technique is much, much more powerful.
Yeah. and less is more, as they say.
Mm.
It really is true here, where as you said, allowing the tissue to go home. And I'm not sure, like that surgery might have been a year or 2 years ago. But what you're saying here is that it doesn't matter the length of time because of the power of the work. And maybe did you want to pull up that other? We've got
yes,
5
I was
minutes.
just thinking that. Let me have a little look at finding. Hang on, I can change the slide for you.
Because I think Tim can
Right. I think you should have the.
Here it comes.
That's it. Okay, good. There we go. So this is an example, the other example I pulled up to show you guys.
Yeah.
So this woman had an emergency appendectomy 7 years ago. She was feeling tethered and uncomfortable behind the navel and the pubis. And looking, you can see why. So can you see my cursor if I do that?
No, sadly.
No. Okay. So let's just describe. Okay. So let's look. They had 1 2-hour session with Scarwork students. I didn't get involved on this at all. So this was just students who've been learning on the course. Firstly, look at the navel before and after. The navel is distorted and pulled down to her left. On the after photograph, you can see, is that as large as we can get that?
Tim, I think you might be able to make that number 2 a full screen by double clicking it.
Great. Okay, thank you. So you'll see on the after photo that the navel is looking much, much more normal. On the pre-photo, it's distorted and pulled. And then under the navel, you can see there's a pleating effect where the scar is very tight. And wherever it's being pulled down and tethered underneath, no wonder she felt tethered, because you can see the pleat under the navel and then it's tethered underneath. And you can see the lines going off to the left of her body, all pulling into that left hip.
Yeah.
And so then you can see also that she's compressed into the left hip. The lines of tension in the groin are stronger in the left hip. And the quality of the tissue, it's very bubbly and puckered. Yes, on the pre-photo. And she's very much pulled in onto the left. Now, after 2 hours, she was obviously delighted with this. You can see she still needs myofascial work. Okay? She still needs fascial work to straighten her up. She's been compensating and tilted for a long time. For all we know, that left side has another problem in it. Maybe it's a baby hip. Maybe she's already got a knee problem. There could be something else. Or maybe that's just the way she was pulled down and she needs probably more scar work, maybe at a deeper level, which is still light. It is still done lightly. It's just different techniques. And I'm sure that she could be corrected. I haven't seen her since then because this was in the north of England and I haven't been teaching in the north of England since lockdown. But this was done just before then.
Yeah,
but you can see you can see the navel is a normal shape. You can see that under the navel, that pleating has almost gone. There's just one tiny little pull at the top of the scar. This is actually an emergency appendectomy. They don't give you a normal appendix scar. What they do is they literally just cut you from navel to pubis so that they can see everything and they can deal with everything.
Yes. Yeah. Makes sense. Absolutely makes sense.
Yeah. So, but unfortunately, no, it was quite a dramatic scar, but now she was hugely improved after that. I was very proud of my students. I was so impressed with them.
I would be too. That's amazing.
Fantastic, isn't it? Yeah, really great. So that's just another example of the kind of things that we work on all the time.
Beautiful. Now that's amazing. I'm going to beg to try to get one more. It was 2. Just Mike was saying that it was 2 years post surgery, which I had a feeling it was a little bit that was quite a long term surgery on the brain, the tumor, which is great because it means in remission at least. One last question before I let you go and do your day. So Whitney's said, very curious as to the effectiveness of this technique on Dupuytren's, and I was thinking about the same thing as well.
Dupuytren's, yeah. So it's interesting, Dupuytren's contractor, isn't it? We actually we're starting to get techniques. Some I've found work really well. Sometimes it's worked really well, and sometimes it hasn't. It's not one of our main techniques. 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 but we do rolling, which is a very, very, very gentle rolling. So if you took your earlobe like this and you just very gently rolled it.
Yep.
Can you see what I'm doing?
Yeah.
It's light, light, light. I'm not throwing it around. Light, light, light. Now, if you can get, or if one of these contractures is large enough and you can just pop your hands around the tendon there, and just the lightest, lightest, lightest roll. I've got one, we had one woman who just did that for her husband every time they sat and watched TV. And she just did that. And that I've known it to help. Featherlight sweeping as well, which is...
What does that look like for people? Just
well,
it's that, isn't it?
It's a two-hand thing, so somebody has to do it for you. But it's basically you are bracing the skin. And when I say brace, so say we've got the flat tummy here. When I brace, it's not like that. It's a brace, a light, gentle brace. And then it's the lightest, lightest, lightest stroke towards the scar.
Yeah.
The lightest stroke. Having said that, and it sounds really easy, but you need to follow the tissue. And if it doesn't feel right, you need to find the right angle. Because say for, if you're working where there has been a retraction pattern, pulling the skin apart so that they can work, for example, on a cesarean, is that a D-retraction pattern? Is it a linear retraction pattern? Because if it's a D-retraction pattern and you're doing linear featherlight sweeping, it's going to be like nails on a chalkboard. Okay. Yeah, so you need to follow the tissue. So nothing's as simple as simple. But featherlight sweeping, you would try different angles and choose the most comfortable for them and what feels right to you, and just gently, gently sweep towards the scar. And you can't do anything wrong with that. So I don't mind showing that one online. But it is not, it is featherlight sweeping. So as though you were taking a feather. In fact, one of my clients started doing that with a feather because she couldn't reach. And so she braced below the knee, and then she used a feather, a long feather, to go from her brace under the knee, which she could reach, down to the foot where the scar was. Yeah. And she really improved the quality of, it really improves the quality of the skin, featherlight sweeping. It's quite stunning. I just think it's one of the best techniques in the book.
Yeah, wow. That's amazing.
Yeah, and it's one of the simplest, but yeah.
I'm terrified. I've got a very good friend of mine who's a golfer. She's just having radiation on her Dupuytren's, and I just, on
the Dupuytren's. I've not heard of that.
No. And I'm not excited about that because it creates scarring.
Of course it does. Yeah.
And burning and everything else.
I mean, laser, having your veins lasered creates scarring.
The ladies, just wait till you're 85 and then have stents.
And then get your scar done.
Yeah. Oh my God, that's so much fun. We've got 2 minutes and I want to plug your stuff mercilessly. So you have your website, but it has a glitch right now. So when you go,
it does have a glitch right now. It does have a glitch.
You can't get on and do any classes because they're all full. They're not all full.
No, they're not all full. There are some spaces, but it's showing up as all full at the moment. Yeah. And there are some spaces. If you can bear with us, we're talking to a software developer, and I don't know what's going on, but I've never seen anything like this on my site, but obviously it's going to happen this week because I'm talking to you guys. Yeah. But no, I run scar work courses in the UK.
Yes.
I'm teaching in Spain next April for people who are manual lymph drainage people.
Yeah.
And who want to learn everything you can do about scarring. I've teamed up with Petra Irvin, who's a specialist. But it is for people who do lymph drainage. But that will be in Spain. If you're interested in that, just drop me an email. I'll put you in touch with Petra. It's a really exclusive, fantastic course. Okay. It's an investment, but it will up your game beyond belief. And we know what happens when you up your game. People come to you.
You can actually put your prices up when you do that, ladies and gentlemen.
Of course you can. Of course you can, because you'd be specializing. Yeah. This is it with scars. You know, if you don't know how to work with scars, I'm afraid this is 21st century. We're missing a trick, because you cannot rebalance people, get them more permanently out of pain if they've got scarring. And that can be tiny scars sometimes, and major scars. You've got a little scar underneath here. There's another picture in the book. You know, you can have that worked on, and suddenly people are saying, oh, I can turn my head all the way around. Is that normal? Because I've never done that before. And oh, I can swallow better. Is that how it's supposed to be? Because I've never done that before, because I fell over at 4 and that was my normal.
And swallowing, how amazing is that?
Actually,
Right.
it takes you 10 minutes to work on that. Done. And then all the tissues loosen up, and yeah, you've got more mobility. It can be that simple.
Listen to the passion in this woman, ladies and gentlemen. It's amazing. I could try to keep you for 8 hours and just listen to you talking, because it's been absolutely amazing. If you want to do the course in the UK and you can't get on the website because you're like going, it says it's down, put your name in the because this is going to be recorded and live for a while. Will be out on our side. I can pass this on to Jan so that she'll
pass it on to me, and then I'll contact you.
Yeah.
I mean, they may have sorted it by this morning. I hadn't checked this morning, but they might have done, but I'm not betting on it.
No. And scarring, we know, releases trauma and emotion. Like
it does. I've got a whole chapter on that in the book. It certainly does. The fascia holds the emotions, as we know.
Yeah. So there's scars and adhesions at the biotentegral approach. That's one book.
Scars, Adhesions, and the Biotentegral Body, published by Spring Publishing.
That's the one we love. That's a great book. Can you see all these like flags and things I've got all over it? I've got flags.
Thank you,
everywhere.
Paula.
Like this, it's gold. It's gold.
And it'll teach you about assessment as well. It'll teach you how to assess properly as well. And you get the link to the first 5 techniques online with Sharon demonstrating them.
And chapter authors, Joanne Everson, love her to death. John Sharkey, love him to death. Graham Scar, funny name.
Great, perfect.
And Leon Blum. So I don't know either of them. I'm going to try to track them down as well.
All great people.
Yeah, so get in and do a course. Join the Fascial Hub. Invest in a perfect way to start looking after people. We've had so much stress and anxiety and isolation with COVID and the pandemic. It's kind of like we're just coming out into a new way of thinking, a new paradigm, and this is really perfect. So thank you so much. I'm just one last little plug for Q Academy. Part of their wonderful sponsorship here. I would normally have this gorgeous thing halfway through, but we just ran out of time talking about how amazing it is to become a remedial therapist or a massage therapist or a myotherapist. So please, if you're interested in coming over and doing a course, your certificate for or your diploma or advanced diploma, or possibly next year your associate degree, then link in with Q Academy. They are absolutely brilliant. I love them to death. They will look after you every step of the way, and you do repeat courses for life. So if you've done your first aid once, then you can come back and do that every year for free. If you've done your like one of the units on sports massage, you can come back and do that every year for free. So they've got so much to offer. Anyway, stick around. Yes?
I've got one freebie for you.
Yes.
Can I just tell you, everybody? Because you saying about the stress and everything that we've been through. It's coming up to Christmas. And it's the stress. And we have every year on the Fascia Hub, instead of the monthly members webinar, we open it to everybody and it's free. So we have Elizabeth Dare Andes, who is a real specialist in taking charge of your emotions and dealing with trauma. She's a most wonderful woman from America, and she is giving us on Sunday, the 3rd of December. Now, the hours might not be right for you, but if you register, and it's all free, you'll get the recording. So it starts at 1600 UK time for an hour and a half. It's totally free, open to everybody. So do share it. But it's basically, you go to the Fascia Hub, FASCIA, the fasciahub.com, and you just scroll down to upcoming events and you'll see Elizabeth Dare Andes, Sunday the 3rd, and just go in, register, and then send everybody the link to the page. Obviously not the link to the registry. that's just tell everybody about it. That's great. And it's on, if you follow us on Facebook, it's on there as well, and you can just share that post. That would be so good. Let
Yeah.
everybody come, and it's how to basically not go to your normal comfort zones, like chucking a bit more sherry down your throat, but actually stay in coherence and in who you are, rather than getting swept up in all this family drama and all this stuff that goes on at Christmas. So really useful, practical work. Yeah.
Wow.
Thank
Amazing.
you. Thanks for that, Paula. I just forgot about that. Thank you.
No. And thank you, everybody, for showing up and being so active. It's been amazing. Don't forget, this will be on a podcast on my website. The link will go over to Jan for her website and possibly the Fascial Hub. And you'll be on my mentorship program. So people who want to get more help with mentoring along their way, their pathway to becoming fabulous therapists, then the mentorship program is the one for you. Brilliant. Jan, stick around. We'll say goodbye to everybody, and then I'll thank you in person after that. So see you later. Oh, Jan,
everybody, take care.
Sending hearts.
I'm sending hearts. Are we sending hearts? I haven't done these yet. There we go.
There we go. Sending hearts. Thank you, everybody. Be well.
Bye. Thanks, everybody. Thank you, Paula. Bye.